we have tricyclic antidepressants. The tricyclic antidepressants, the English will not ask you of what they are, but know some of the examples. Imipramine, nortriptyline. So when you hear of nortriptyline, and later you go and hear of amitriptyline somewhere, you should know that they are all the same. So these are tricyclics. We have the tricyclics I think they are part of the old ones. Okay. They are part of the old ones. We have monoamine oxidase inhibitors, MAOIs. And for those ones, we have phenelzine, isocarboxazide, and tranylcypromine. Please, this drug, at least that's why we've put it in I mean, we've designed a nice way to keep them. We have phenelzine, isocarboxazide, tranylcypromine, and selegiline. This one, the English likes it a lot. It got to a time about it, tranylcypromine and selegiline, or selegiline. Pits. Remember pits? Someone will also say spits, but pits is easier. So remember this. I'll tell you why you should keep this. Maybe with time we can capture it, but try and capture it. It's of importance. Then the next class you can talk about is the selective serotonin reuptake inhibitors, SSRIs. SSRIs. And examples are the citalopram, fluoxetine, sertraline. Sometimes some people confuse sertraline with what? Selegiline.
Exactly.
You are one, eh? So when you hear, so all the tricks I can remember, I'll make sure I'll share it here so that, so when you remember selegiline, selegiline, the one with the G, just take it in your mind that it's part of the MAOIs, monoamine oxidase inhibitors, selegiline. All right, but there is something. Well, I think as we move on, I'll let you know. So selective serotonin reuptake inhibitors, SSRI. When we talk about serotonin, they are all how do you call them? Neurotransmitters, right? They are all neurotransmitters. Please a minute. They are all neurotransmitters. So I will not go much into how they work because the English will not ask you that. The English is a safety exam. Most of the time, safety issues is what they normally ask. And we will look at some of them. Someone is doing this or someone is having this condition. Can the person take maybe sertraline? That is one. Someone who was on, let's say, sertraline for about 2 months, the person saw no change. And now the person wants to switch to what? Selegiline. What is the safety issue there? You see all of these things. Okay, so we'll talk about all of them so that we know how the English asks questions on these things. Not keeping the names like that and what you might not listen invited and you go your way. That's not how the English behaves. Okay. Kindly mute up. Okay. Then we have atypical antidepressant too. So that is where we have digoxetine, bupropion, and trazodone. Okay, so these are atypical antidepressants. I think these ones are the atypical are the new ones, okay, or the new generations. Right. So we have this one there. Uh-huh. So take a look of it. Take a good look of it, especially with these
Perfect.
main three. Then these ones are the modern ones. Any question? All right.
Yeah, hello. Yeah, please, I just wanted to I realized that I'm trying to like write. Should I take notes or I should just listen? I'll get the slides later or something.
Okay, so most at times we share the slides, but we don't share it
Okay.
until the topic is completed.
Mm-hmm.
Okay, but after every class, we share the recording on the page. So you'll have access to the recordings for 30 days. Okay.
Okay.
All right. So let's pick the first one and the tricyclist and see some of the nursing um precautions or those things that we should know about them I mean, as nurses. Okay, so tricyclic antidepressants. We are saying that their therapeutic effect occurs in 1 to 3 weeks. Their therapeutic effect occurs in 1 to 3 weeks, with maximum effect in what, 6 to 8 weeks. Do you know how the NCLEX will ask you questions on even the first point? So we point out some of these and so that your eyes will be widely opened. So when they give you a scenario that a person has been taking antidepressants, especially this tricyclics, and they tell you that maybe the person has been taking it for about 5 days, and the person tells you that he or she is worried because he has not seen any effects of the drug, what would be the right thing to tell this patient? So having the idea or the knowledge that tricyclic antidepressants will start working from 7 days up to about 3 weeks, you know what to tell the patient. So when you have this idea and you have these options given, and the options, all of them will portray or they will appear to be very reasonable, right? Most of the times, the wrong answers are those which are more appealing. I mean, they look more appealing, right? Something like that. They look nicer and they'll be saying, choose me, choose me, choose me, something like that, right? So that is how they can ask the question. And for you to see a maximum or a full effect of it, it should be from where? Somewhere approximately 2 months. Okay, approximately 2 months. So from 6 to 8 weeks, you should see a maximum effect. So always pay attention to details. What the question will ask you, and you know how to bring the answer out. We are saying other uses include treatments of what? Chronic insomnia.
And I'm gonna do it again.
Is the person talking to us?
I'm the massive.
Okay, let's continue. So you can use it also to treat attention deficit hyperactive disorder, ADHD. And don't worry, our new people who joined us recently, you'll get to know of it. Okay. It's also one in place. I mean, everything we are doing, you meet it and you appreciate it. You'll never know what the power of what you are going through until you go and face it and you pass. Mm. So don't worry, you meet it in your schedule. So it's also used to treat panic disorders. Tricyclic antidepressants taken with monoamide oxidase inhibitors can lead to, so this one, always keep it in mind that I don't know whether I have it summarized even ahead, but right now, keep it in mind that you can't, there is no way you can be on two antidepressants at the same time. Have it in mind like that. So you can't what? you can't be on monoamide oxidase inhibitors and also be on what? Tricyclic antidepressants or any two types of antidepressants at the same time because of what? Issues of hypertensive crisis. You can get hypertensive crisis from what? Adrenergic stimulation of the heart and blood vessels. And there's also a nursing concern about that. Even when you are switching, I don't know if I'll wait and see if we have it on the slide. If not, then I'll tell you about that one. Even let's say someone has taken, or let's say someone has been taking one type, and we don't see it to be working, and we want to switch. You can't just switch on the same day, okay? Because most of them they have anticipated, like the trough levels, or some of the medication will still be in the patient. So we have a time frame that you should most of the times between some say the bigger gap is between 1 to 3 weeks for you to be able to switch, even between antidepressants. The next one to talk about here is we are saying it exerts anticholinergic action of their own. Tricyclic antidepressants exert anticholinergic actions of their own. So that's the intensify effects of other medications with anticholinergic actions. So what does this sentence tells you when you are learning? So it means that whenever you are taking tricyclic, let's say, and they will not, in the question, they will not tell you tricyclic antidepressant. They will mention a name. Okay. They will mention a name. You remember some of those names. Look at here. Sorry. You see, imipramine or tryptylene and amitriptyline, I mean, all of those drugs. So they can mention any of them that the patient has been taking this medication and something. And the person is also taking something, any form of anticholinergic, whether benztropine or whichever. Please mute up if you're not talking to us. Kindly mute up for us. So they can give you any of them. They can give you any of them. So you have to know that they are tricyclics, and because they have this form of what? Anticholinergic property in them, you shouldn't take any form of anticholinergic like benztropine and the rest when you are on tricyclic antidepressant. So whenever they ask you a question like that, most of the times they will ask you which of the following will the next question. A patient has been discharged on imipramine, then they can give you the dosage and they will ask you which of the following. Can you mute up? Not sure. So they will ask you which of the following statements by the patient is of the greatest concern. Which of the following statements by the patient is of greatest concern? And there'll be a sentence like patient states that he has been taking benztropine for something. Okay, then you know what it means. It means that sentence is what of great concern, and you have to inform the healthcare provider for changes to be made. All right, the next one. CNS depression also happens with what? Tricyclic antidepressants. Okay. So you avoid anything that depresses you, like alcohol. Antihistamine will depress you. I mean, it will bring you down, something like that. You see, we have downers and uppers. I pray that before this class ends, we will go through. The last time I think there was a confusion about understanding uppers and downers. It's very simple. Okay, very simple. We'll look at that. So avoid, opioids like morphine, whenever you give to a patient, it has this sedative effect. Barbiturate, it has this sedative effect. Alcohol and antihistamines like that. So that is what this point is saying. Any question on this one before we move on to the next? If not, then we move on. If you don't have question, I have questions for you. Let's look at the next one in brief, and the nursing considerations we can talk about. So monoamine oxidase inhibitors, because of potentially fatal, food and drug interactions, monoamine oxidase inhibitors. Mr. Presla, you want to ask a question, right? Kindly unmute and talk.
Okay, please. I wanted to find out the side effects of the drugs that we just did, the TCA and the MAOs.
Okay, so some of the side effects we talked about, look at this point. It has this sedative, their therapeutic effect is to what? Is to elevate you when you are depressed. That's why they're called antidepressants. Some of the side effects is sedation. Okay. Side effect is sedation. Difference between side effect and adverse effect is that when we talk about adverse effects, it's like a side effect, but a more dangerous one and not expected. Okay. So when it comes to sedation or CNS depression, it's a side effect of tricyclic antidepressants. And it has a tendency of elevating high blood pressure. I think we have some which also runs across all of them. And maybe by the end of this, the last one, we will see some of them. Okay. So for now, what we can talk about is what? Is sedation. Then we can talk about, when we talk about anticholinergic actions, you know what anticholinergic actions that, they do. We have, I don't know if you know of this nice saying, I can't pee, I can't cry, I can't what? Urinate.
I can't shit.
You can't shit too. So it's like, it is drying up every mucous membrane, something like that. So you see, I can't pee, urine retention. If you can't shit, it means what? Constipation, isn't it? If you can't cry, it means it reduces what? Like it dries up mucous membranes. Okay, so like it reduces any form of fluid, something like that. Okay, so when we say any drug has this effect of anticholinergic effect, or it has anticholinergic actions, you think about these things. Okay, we talked about elevation of blood pressures and even heart rate. That one too is part. Okay, I don't know whether we have it on this slide. We will see. But these are some of them. When you understand the concept, I think when you get questions on that, you can answer. Are we there? Do you know why? Look at this one. Do you know why these antidepressants, they are used to treat insomnia? Who can tell me? It's very simple. Who can tell me?
Can
Because they have this sedative,
yeah. So I think it's in the last point. I mean, we have
Good.
said that it depresses the CNS.
Good.
And then it causes drowsiness or something. So
Good.
Obviously, it's the other way action. So
Good.
it helps with insomnia. Yeah.
Good. So you see, the idea over here is not about something like we don't want to encourage what from day one. Those of you who have been following some of our slides, you know that most of the slides, they are not like what is this, signs and symptoms of this, complications of this. I mean, they don't follow that, should I say, nursing school notes or something. Like, we try to understand the concept so that when questions are asked, those of you who have been following us for long, you see how sometimes our slides are, so that you can understand the concept and make applications. That's what the English wants. Okay. All right. So I think by understanding how they act or their action, whenever we are asked any side effect like our sister asked, we can relate and tell. Right. Okay. So let's pick it up again here. Monoamide oxidase. Please, our sister who has a question, please, do you understand it now? Is it fine? Or we are still not okay? Or she's not here? Sister Becky, you want to say something?
Yes, so Basima.
Okay.
And please, with regards to the side effects of the TCAs, I think you can even abbreviate the name depicts itself. So from one of the archives, they said that TCAs, you can use the same the first letters to remind yourself of the side effects. T for tachycardia, C for cardiac arrhythmias. So they have to be going for weekly EKG, yeah. And then A for anticholinergic side effects, and then S for sedation or sexual dysfunction. So those are the side effects, yes.
Okay. 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 Thank you for bringing that one to us. Thank you. Okay. Yes, any other contribution, subtraction? If not, then we can
Please, I want you to
continue.
tell Becca to put it on the page.
Okay, is that okay?
All right, I'll do that.
Someone wants to. So let's talk about this one. So because of potentially fatal food and drug interactions.
Give me small plate inside. Yes.
Kindly mute.
Hey, give me small plate inside.
Kindly mute. Okay. So because of potentially fatal food and drug interaction, monoamide oxidase inhibitors are not a first choice to treat depression unless client has atypical depression. So I think it's very clear. I don't know if some of you remember the theramine. I mean, we will look at that. Okay, but because this kind of antidepressant has lots of food and drug interactions, so they are not, I mean, used to treat depressions. I mean, they are not used as first-line treatment. Contraindications. Clients over the age of 60 years or those with pheochromocytoma, heart failure, or liver disease. So when you have, this one is adrenal issue, okay? Then you have heart failure, then liver disease. So these are contraindications to using monoamide oxidase inhibitors. Now you are saying taking monoamide oxidase inhibitors with selective serotonin reuptake inhibitors can cause something we call serotonin syndrome. When you hear of serotonin syndrome, think about some important vital signs going up. Like it's like an upper something. Everything goes up. Serotonin syndrome. So think about blood pressures. You know, over here, we have some of them here, just agitation, sweating, confusion, fever. Okay, I think the rest continues here. Hyperreflexia, tachycardia. You have hypotension, rather here. Muscle rigidity, ataxia. So because of these things, you have to avoid what? monoamine oxidase inhibitors with selective serotonin. So this is an necklace point. This is an necklace point. Do not take them together. And on the necklace, they will not say MAOIs and SSRIs. They can give you, let's say, selegiline, okay? Then this one too, they will give you which one? Examples of SSRIs. Any fluoxetine, right? Sertraline, yes. Sertraline can give you sertraline. So sertraline, then they also add, if most of the time they don't combine sertraline and selegiline, they can maybe give you sertraline and maybe isocarbonic acid. Then if you, you should think about having this what serotonin syndrome if they are used together or combined. Okay. Sister Becky, you have something to say?
Oh no, please, it's an old hand.
It's an
Sorry.
old hand. Oh, okay. All right. So hypertension drugs potentiate hypotensive effects. Sorry, antihypertensive drugs potentiate hypotensive effects of what? Monoamine oxidase inhibitors. Okay, antihypertensives. So if let's say someone is being treated with labetalol and has been prescribed with isocarbonic acid to treat a long-standing depression, you should look out for what the next questioning this kind of thing, okay, because of the hypotensive effects. So always it depends. You can get one same question, but it depends on the answer choices that you get. But if you have knowledge on the drug, we are not saying know all, but know what matters, then you'll be good to go. Okay. So monoamine oxidase inhibitors have the capacity to bring your blood pressure down. So the use of antihypertensives can potentiate hypotensive effects. Good. Then, so this was the thing I was trying to say. I think it's a type of protein, a kind of protein. Dietary tyramine. It is found in some foods and some drugs, like tyramine. So dietary tyramine, you are saying that some other dietary constituents too, and indirect acting symptomimetic. So this symptomimetics, sympathomimetics. What you mean by sympathomimetics are like herpes. So when you hear of sympathomimetics, think about herpes. When, I don't know if you've listened to Mark Clement before, when we talk about herpes, drugs that elevate almost every vital signs. And drugs that elevate almost all vital signs. So if you are here, you know your herpes and your downers very well, I think you can catch it up easily. Amphetamine, methylphenidate, ephedrine, cocaine, they are all sympathomimetic. Okay, sympathetic nervous system, they act on that. And sympathetic nervous system sends almost all the normal vital signs we have, blood pressure, heart rate, send them all up. The person can have agitation, anything that makes you hyperactive is what's with sympathomimetic. So the dietary tyramine and some other dietary constituents and indirect acting sympathomimetic, these are examples, can all precipitate what a hypertensive crisis in clients taking monoamine oxidase inhibitors. So what does it tell you? Someone who is like a drug addict and they make mention of cocaine, you should know that the person cannot take monoamine oxidase inhibitors. ephedrine, methylphenidate, amphetamine. Mm. The methylphenidate is used to treat attention deficit hyperactive disorder, isn't it? Methylphenidate. Yeah, it is used to treat that one somehow. So with time, the drugs, you get them small. Sometimes they become plenty in our heads, but I mean one after the other. Okay. The drugs, if you are here and you are done with your tax 5, find some time and do your pharmacology again. And I promise you that this time when you are going through, you will meet lots of things that you even ask yourself that, I mean, were all of those things inside the book when you were reading at first? Okay, you'll find, I mean, your eyes will be opened and you will see lots of things in there. So that is it. Dietary theramine. You look at some of the theramine containing foods and all of that. When you are, I think I shouldn't rush. They are on the slide, so I shouldn't rush. Any question on this one? Any question? Please, who is there? Someone is joining us with the name Dell. Who is Dell? Who is Dell? Dell. If the person doesn't respond, can we take the person out? We can recognize this name, Dell. Please, if you are here and you've not changed your known name, a name that we know you with, kindly do so. And if you don't do it and you are taken out, even if you do it again or you correct it, you can't join this class again because you were removed, unless maybe the next class. So who is there? Is Amingo here? Okay.
Hello.
All right.
Hello.
Yes.
Yeah, I'm busy. I'm using my laptop. Sorry, I was far from the phone last time.
So you are using the Dell, eh? That name Dell.
Yeah,
Oh,
yes.
okay.
Please.
Okay, all right. Yes, boss. Okay, let's continue. So let's look at foods to avoid or to limit when taking monoamine oxidase inhibitors. Please remember this first line here. We are saying because of what the potential, like because it has a potential food and drug interaction. Over here, our main focus will be with the food. Dietary theramine. We don't want to take anything containing much theramine when you are on monoamine oxidase inhibitors. When you hear of MAOIs, remember your pits. Remember your pits, and you are good to go. Okay. So this dietary theramine that we talked about, this is it. Some of the foods to avoid. So dairy products. And what do we mean by dairy products? Examples are what? Aged cheeses. So when you see something like aged cheese, please, we have some form of cheese that they can take. They have very less or almost no theramine. So most of the times, if you want to be sure that the answer choice you are choosing is correct, look out for this thing, aged cheese. Okay. And let me say this before I even forget. Anything that has fermented, they can't take it because fermented foods are likely to contain theramine. So they can't also take it. Okay, so when you're on monoamine oxidase inhibitors, those pet drugs, you can't take some dairy products like egg cheeses. So sometimes they can give you the name of their special food, some of these things, as you can see them here. Sometimes, surprisingly, they bring some of these foods. Okay, sour cream or ice cream. Then yogurt. They can't take it when they are on what? On the amount of these inhibitors. Then when it comes to meat and fish, when you see aged, aged or cured, so such as hot dogs, they can't take hot dogs, they can't take bologna, they can't take what? Pepperoni, salami. I think these foods, they normally, I've been seeing it a lot. Those of you who have been seeing it, you can relate. So they can't take all of these things because of theramine content in them, high theramine content. When they take it, what is likely to happen? When they take it, what is likely to happen? Yes, something like that. Is it serotonin syndrome or hypertensive crisis? A question for the
I
girls.
didn't hear
I
what the
think
girl
it's
said. Oh.
serotonin syndrome.
It's serotonin syndrome. Okay.
If they take the drug with
Theramine.
those foods,
No, when they take
okay,
high theramine containing foods. Okay.
foods, okay,
They can
with the
have this.
drug,
Yes, with the
serotonin
drug. Yes.
syndrome. Okay.
So you can look out for most of these food over here. Okay, hot dogs, bologna, pepperoni, salami, sausage, egg,
Pepperoni.
cheese, and the rest. And
Hello,
some,
boss.
yes.
Please, in case they are giving us option of this cheese, and there is no aged cheese, how do we differentiate between that cheese and the other cheese that you are talking about that they can take? Is there any way we can know that is that one that they can take?
Okay, so I think this is also another example of the cheese, the bad ones for the MOAIs. This is an example of a cheese, Roquefort, blue cheese, bright cheese, and camembert. I don't know, but these are the examples of the bad ones. If you see any other cheese, you can Google from your end and see. I can't give an exact example, but you can Google from your end and see. You will see that there are some cheeses which are allowed. But these ones written here, they are the worst ones that they can't take, no matter what they shouldn't take. But I just mentioned it because I've seen a question before which gave an allowance for that type of cheese. And when you're a beginner and you see cheeses, you think it's all cheeses. Most of the times questions do not want to stress you plenty. So you see aged cheeses. When you see aged cheeses, they are okay. It's a no-go area. If you don't see aged cheeses and you see any of these ones,
Okay, sir.
Roquefort, blue, then you should know that it's a bad one. If you see any other type, think it's allowed. You can, if anyone has searched any type and has seen, the person can bring it out. Those ones can be allowed. Cheryl, you want to say something?
Cottage
Yes,
cheese.
good,
Cottage.
good. So they can take cottage cheese. You see that thing?
Okay, thank you.
You are welcome. Mr. Cheryl, you have something to say?
Yeah, I said cottage cheese.
You said it. Okay. Thank
Yeah,
you.
thank you.
You are welcome.
Baby. I'm in Toronto, baby.
All right,
Sure,
let's
sure,
continue. Kindly mute up first. So fruits and vegetables, so not all, but some. These are examples, like canned ones, canned figs. From a fig tree, canned figs. They can't take it. They can't take what? Papaya products, which is pawpaw, right? Is it pawpaw? Papaya is pawpaw, isn't it? Then, including meat tenderizers, they can't take it. Raisins, they can't take it. broad bean pods, they can't take it. Tofu, tofu is one of their good foods that they normally enjoy. You can't take it. Soybean extract. So these are sometimes the foods, when you get it on the anklet, it's very, like, it's disheartening, but well, what can you do? Occasionally, you see that some of them will be appearing. Any much, like, I don't know how many you can just keep it in there, but you can take note of some of them. Then alcohol. Most of the time, they don't mention alcohol, they'll mention beer. When you have beer, think about alcohol and see whether alcohol is actually okay in this sense. So whenever you see beer, think of alcohol, okay, and relate and see whether in that instance that you are asked, I mean, something should be questioned about it, or maybe, yeah, okay. And wine too. Wine, sometimes wine and beer likely to contain what? Alcohol. So this is an example. Then we have some others that you shouldn't also take when you are taking monoamine oxidase inhibitors. Look at them, they are here plenty. These extracts, so all of these things. Then these are, please, the drugs. Let us skip the drugs. If not anything, for the dairy ceramic containing foods, we can hot dogs. Hot dogs are common. This pepperoni, salami, sausages, and this the aged cheeses and the rest. We can keep all of them. They are easy to remember. So at least you can keep them. Then with the drugs, take note of them. It's very important. Do you know one good thing about these things? You will not see it being like this way. You go and meet a nice person, well-polished one, and it will be like something that, remember, I always keep saying this. The NCLEX is a safe exam. The NCLEX is always a safe exam. So remember that these drugs, you shouldn't take them with what? Monoamide oxidase inhibitors. Don't take other, you see, other antidepressants, whether tricyclics or SSRIs. Don't take any of them with monoamide oxidase. I mean, generally, you remember I said it, generally don't take any two forms of antidepressants at a time. Unlike some antihypertensives, sometimes doctors prescribe two different antihypertensives to take. Some drugs allow that, okay. Sorry, some conditions and their drugs allow for that. Diabetes, you see, it's an example. You can take two forms of treatment. Sister Benedicta. Okay, let us kindly mute up. Okay.
So,
All right, let's continue. So take note of them. Okay. Oh, please mute up. All right. So you've seen the drugs. Can we continue? If you have any question, you can ask before we move on. Okay. So these are some foods. So you see, look at these ones. Good. That's why sometimes I don't want to rush through the whole thing. I think they're even here. So all these forms of cheeses, they are okay. Okay. All these forms of cheeses, they are okay. Please, for alcohol, especially with the wine, but alcohol is generally not good. Alcohol is generally not good for any medication, okay? But when you have the option like a wine, compare and see whether you have a worse answer, okay? Like you have a worse option in there that is capable of doing harm than wine, okay? But please, the beer is no. The beer is a no-go area. But the wine sometimes. But still, compare answers and see. If there's any best one you can choose over this, choose it, because alcohol is generally not accepted. It is some of the fruits and vegetables you can't also take when you are with, I mean, you have to be cautious when it is not contraindicated though, but you have to be cautious when taking them. And some other medications, so other foods and other medications too, so they are here. Please, these ones are not actually, please, this one, have you seen this? This one to consider and see, okay? Consider and see. Did we say that which drug or which of the antidepressants cause this anticholinergic effect? Is it the tricyclics or monoamine oxidase inhibitors or all of them?
The
Who can say that?
Tricyclic.
Tricyclic.
Tricyclic. Okay. So this one too, when you are using the anticholinergic agent with monoamine oxidase inhibitors, it's not contraindicated like the tricyclic, but you have to be cautious. You see, insulin. Why? There's a reason for all of them. Let's take insulin for instance. Insulin can potentiate what? This monoamide oxidase inhibitors can let you get some form of what? Low blood sugar. Okay, it can give you some form of hypoglycemia. So when it's like it's potentiated, okay, when you're taking insulin and you take monoamide oxidase inhibitors, it can potentiate your hypoglycemic effect. That is why we are saying that it should be used with caution, not an absolute contraindication. And this one too is the same thing for the same potentiating of what? Potentiation of hypoglycemic effects. This one has its reason. This one too. Okay, and the rest. All right. Any question? If not, let's look at the last ones. SSRI. And know that these ones, they are all antidepressants. Let me give you a scoop of the whole thing. I don't want to, because that one too alone can lead to lots of things. I don't want to go into details there. The should I say the pathway how most of them work. But look at serotonin, selective serotonin reuptake inhibitors. They are all neurotransmitter actions, right? Okay, they are all neurotransmitters in play. So at the end of the day, the effect of these things happening here, this selective serotonin reuptake inhibitors, if you understand the concept of serotonin and what is happening in relation to the mode of action of this drug, the name itself, you will even understand. But just know that in all, it will help boost you from becoming what? Depressed. Okay. What this one does is that it blocks, as the name implies, it blocks reuptake of serotonin and intensify the transmission at serotonergic synapses. Then the effects are often seen. So it's like it concentrates, you see, whenever serotonin works, okay, it's like they are being broken down. But this one helps to save all of them and direct them to what? Synaptic or like synaptic joint, or let's say synapses is like a joint, or let's say an area where there is transmission or there's exchange of what? Messages between two neurons at the exchange points. That is where synapses normally occur. It's like we are increasing the effect of what? Serotonin at a particular synapses to help elevate you, something like that. That is in a shallow way. Okay, not to go into details because it's a bit technical. But it helps to increase your serotonin level at various synaptic areas. Then the effect is seen after. So you see, most of them, you are not likely to see the effect in less than a week. So take note of that. The effect is mostly seen after 1 week, mostly up to 3 weeks. That is the time that you start seeing a positive change. Okay, but it takes more than a month. Okay, it takes a bit longer time for you to see the full. So that's the difference. When it begins working and when you see the full effect, the two things are different. Okay. To prevent serotonin syndrome, SSRIs should not be taken with what? MAOIs. We've talked about this already. If a client is on a monoamine oxidase inhibitor and is transferred, so this is also an necklace point. I've seen, I think someone has even met it before. This one. Okay. Like the example I was trying to tell you, someone was on maybe a particular, and they will name the drug, and they will tell you that the drug has not been working for the person, and we are switching the medication. Okay. So you see the time difference even here. So if a client is on MAOI and is transferred to fluoxetine, which is an example of what selective serotonin reuptake inhibitors, at least 5 weeks should elapse before beginning what fluoxetine. Please, sometimes you see you have to give room for the drug to fade out before. Please, sometimes in some books you see 3 weeks. That is fine. If you have 3 weeks and 5 weeks, they choose the longer time. Okay. If you have 3 weeks and 5 weeks, choose the longer time. So this information is from Pearson, one of their things in there. So if a client is on monoamine oxidase inhibitor and it's been transferred to fluoxetine, at least 5 weeks should elapse before beginning the fluoxetine. Now we are saying to transfer from fluoxetine to monoamine oxidase inhibitors, at least 2 weeks should elapse before beginning. So you see, so what does it tell you? It means monoamine oxidase inhibitors have a longer effect, right? It has a longer effect. So you have to let the medication go down to wear off before you start what? An SSRI, especially the fluoxetine. And it will take approximately these 5 weeks for this monoamide oxidase inhibitors to leave the body completely before you can start fluoxetine. Otherwise, you will have this serotonin syndrome. Okay. And if, let's say, the person was already taking fluoxetine and the fluoxetine has not been helping, we want to transfer this patient from fluoxetine to maybe tricyclic. Then what do? We have to allow for 2 weeks. 2 weeks before. So I think this one too, we can keep it. It's an English point, very important. Then in a client taking fluoxetine and warfarin, you have to monitor for coagulation. You monitor coagulation closely because fluoxetine is highly bound towards plasma proteins and may displace other highly bound drugs such as warfarin, which means that it will not allow some anticoagulants to work well. That's what it means. Okay. It will not allow some anticoagulants, especially warfarin, to work well. So when they give you a question like a person with atrial fibrillation, has been taking warfarin at home. Okay, but maybe for the past few days, the person has been diagnosed with what? Severe depression and has been prescribed fluoxetine, okay? And fluoxetine has been prescribed for this patient. You have to look out for drug-to-drug interaction. What is of your concern? Note that they give you a history of the atrial fibrillation and the warfarin that the patient was taking. They've given you that history for you to be able to make to make a decision. That history was not given to you in vain. That is one strategy when you are doing English. Okay. Most of the times you see two sentences for a question. The first one is normally a preamble. Then the second part of most of the questions on the English, they are like two sentences. No matter how long they are, most of them, I'm not saying all, no, like the standalone questions, most of them are two simple questions. And the first aspect is likely to be a preamble. Then the last part will be the question itself. But note that the preamble is always given. That is one trick. Open your eyes well. When you start practicing them in your normal quizzes you do with us, you will appreciate it. You will see that the first part is just a preamble. That gives a clue to what the answer could be. So sometimes you can have all options to be correct, but the preamble given, they want you to choose one particular answer. Okay, so let's take note of it. Then what else can we say? Access for suicidal tendencies, especially, I think this one, McKay even said it, especially when you're switching among antidepressants, especially for younger adults, for younger ages. You have to be very, very careful for suicidal tendencies. So whenever you see a question like that, suspect what? Especially when it's very new to that person, or we are switching among antidepressants. Please look out for the tendency of suicide. It's likely to be suicide, unless maybe you have different answer options there. Then what do we have here as our last point? Restrict amount of what? Drug available to patients to prevent overdose. So that one is a safety concern. Don't keep these drugs closer to a patient, okay? Because they can even use it. You know that sometimes patients even store up some of these antipsychotics, some antipsychotics and some of these antidepressants things for suicide. You want to keep them plenty, then try and swallow them at once so that they can die. So you don't have to keep these medications more closer to them. Any question? If no question, then I have questions for you. You see that when we started these things, I haven't asked you any question, and all of them are piled up here. So my first question here, let's see how we can relate. The client is reporting vague dread, The client is reporting vague dread. She is pacing and hyperventilating. Her jaw is clenched. So this one is from the antipsychotic. These questions are coming from what we did last week. What we ended with last week. Then with what we've done today. Okay, so her jaw is clenched. As soon as you are reading this, then you should be thinking about what is happening to the patient. And she is wringing, you see the ringing, she's wringing her hand. What type of medication should the nurse include that this client needs? Wait, before anyone begins to answer, what do you think is happening to the patient? That will help us more. What do you think is happening? Oh, no one.
Anxiety.
Are you sure?
Let me try.
I don't know. I am just asking.
Is it not manic
I'm,
face?
are you asking, or you should start by saying it is not, is it? I
It
like,
is.
it is manic face, eh? Yes, who else wants to try? Okay, let us look at the answer straight away. What do you think the answer is?
Isn't it extra pyramidal effect?
Hey, you're also saying, isn't it? You're all afraid of it, is eh? Okay, so Let us look at the answer. Who wants to choose the answer? Who wants to try first? Should I mention names? Maybe I should look out for names and mention, right? Should I mention names? Someone said anxiety, eh? Is the person here?
Yeah.
What made you choose anxiety? Let us learn from what she will say. I don't know what you're about to say, though, but we are all listening to you. Why did you choose anxiety? Oh, you don't know why?
Maybe because of the hyperventilation. Ventilation and pacing. I know
The
Okay.
hyperventilation.
Okay.
like
So you see,
when
you
some
see,
people
mhm,
honest, sometimes they clench their jaw, sometimes
okay,
to lead to like to anxiety, something to make them feel a little better. When they like that, they hyperventilate, like their breathing goes up and all that.
very good, very good. I like your observation.
And
You
the
see,
vague death too.
good,
So it's not something real.
good. So what's the meaning of big dread? What's the meaning of it? And one thing I should also say is that the English make good use of a quality English. Okay. So if you're sometimes their language is very different. If you are here, you've tested before. I think you know what I'm talking about. Sometimes they are wording. If you don't understand the concept, it's something. What's a big dread?
It's
You want to
it's
understand?
a feeling of dumb feeling, as if you are. So when somebody is feeling the, I don't know how to explain it, but it's not something real.
Good, good. It's like you're unable to think clearly. Okay. When you have the vague itself will even tell you. Okay. It's like you're trying to hide something, you're not feeling well, uh, having an uneasiness with yourself, something like that. So the person reports vague dread. She's pacing. This pacing should even give you, and hyperventilation should give you an idea of what anxiety. So if, let's say, there was another option here like bench stroking or something, do you think these things, though the second part could give an idea of maybe an anticholinergic something, but look at the first part. Do you think the first part will agree to what? To anticholinergic effect? Will you decide that? I don't think that will give you a clear, because
No.
someone who is having who is having cholinergic crisis, okay, someone who is having cholinergic crisis will not be doing this thing, pacing, hyperventilation, the rest. You can see this jaw clenching and this ringing, maybe, okay, and some other things. So what's the answer? We've answered it right. Someone who is exhibiting anxiety will need what?
Anxiolytics.
So that is very easy. Do you all agree? Do you all agree?
Yes.
Okay, all right. Yes, so that's our answer. Anxiolytics. Let's read the rationale. Can we move on to the second one? Let's take the second one. What would be a priority clinical problem to address for a client taking zolpidem? Do you remember zolpidem? Do you remember? Hello. It has fallen into water. Eh? Please, do you remember zolpidem?
Yes.
So, what is it? What is zolpidem?
I know it's used to treat insomnia.
Okay. Insomnia and what?
That's the only thing I know about it.
Okay. So let us take it that way. Okay. Let us take it. So it's like it's a CNS depressant, isn't it? Something like that. Right. So let's have that in mind, or let's have that idea and try and answer. What do you think the answer will be?
Then it will be sleep disturbances.
It's in which one? Sleep disturbances.
Yeah, the three.
What will be a priority clinical problem to address for client taking zolpidem? So why do you choose 3? Because you are saying that zolpidem helps with what? Sleeping, right? It helps
Isn't it
when you have
one?
trouble sleeping.
So the answer, I think, is A, 1. Reduce
Yeah, I
ability
also
for
think it's
sleeping.
So why
Because
do you think it's 1?
the person will be oversleeping, so he will lack ability to do certain things by him or herself.
So wait, if someone is oversleeping, does it mean that the person has a reduced ability to take care of him or herself?
No. The answer should be 3. Because that means the drug
So
is
you
not
see?
working. The drug is not
Yes,
working if the
yes,
patient
yes.
is not sleeping.
Good, good. You see, you have a drug. I think we have similar one. Those of you who have seen this question before, someone who has like a mechanical implant, okay, let's say a heart valve, and the person has been taking warfarin for about 3 months, and the INR is 1, or let's say 1.5. The INR is 1.5 for someone who has been taking what? Warfarin over 3 months because of what? Because of a mechanical heart valve that the patients have. What will you do? If the INR is 1.5, what will you do for someone who is taking warfarin for 3 months? You have to report it to the healthcare provider. And what does it mean? It means the drug is not working. And someone with a mechanical heart valve, you should even expect an INR, the least one should be 2. But you always want to keep it even between 3 and 3.5, no more than 3.5. Okay, for normal people who are being who are being given this warfarin to treat conditions like atrial fibrillation and the rest, to prevent complications from atrial fibrillation and the rest because of what? We want the INR to be between 2 and 3. But for people with mechanical valves, we even want it to be between 3 and, the maximum should be 3.5 because we don't want clot to develop around these artificial things in the implants, okay? So it is the same for this one too, like a similar, you can make a link. You are giving something to treat someone who has trouble sleeping, and the patient is complaining of sleep disturbance. So that's the answer. Can we move on to another one? Are we learning? Are we learning? Let's move on to the next one. A client has an order. Is someone asking a question? A client has an order for 30 milligrams of flurazepam. The next determines that the client understands the effects of this medication by which statement. So this is how your final day will appear. You meet drugs that you don't know. But look at the ending part, the suffix. What does it tell you? So use that one
Diazepam.
to answer. Mhm.
I think that's a thing.
During the diazepam family, must realize that.
Who wants to answer?
3.
3.
I will take my medicine, go straight to bed, and to go and sleep. Are you sure it is 3?
It doesn't work immediately.
Understands.
So it means you're looking for a correct sentence, right? A correct statement. Me, I was just asking you. It can be 3, it can be any other. I'm just asking. I think I should mention names. Some people don't want to talk today. Mr. Sylvia, are you here? Or you've talked? Mr. Sylvia, what's the answer? What do you think?
I think it's 4.
You think it's option 4?
Yes, the answer is 4.
Eh.
Yes. I also go for 4. It's 4.
Please, don't follow the crowd though. Say yours too. It's like India or South Africa. Everybody will go on his or her own. Is
Go
that Sharon?
straight to bed and go to sleep.
The next day I'll go to work.
I'm also thinking
I
about
will
2.
choose 3.
You are thinking about what?
3.
2.
Why 2?
Yes, I'm thinking about 2 too.
Okay, so I was thinking that the medicine will not actually, because I'm thinking that the medicine.
Yes, the medication will not start immediately you take it. So when you take it, you prepare your bed. By the time everything you go to bed, then the medicine will start working. And also it wouldn't allow you to wake up early in the morning as usual, so you might be late. So you have to prepare everything.
Exactly. Well settled. Exactly. Okay, well settled. So that is it. The answer is option 2. You see how the thing is. So you see, when you go and you meet questions like this on the NCLEX, you yourself, you admit that the questions are not difficult. But still, you can't answer. That is how the NCLEX can pay you. Because I've not seen anyone who has failed and has genuinely reported that the questions were difficult. I've not seen anyone. Like, the questions will be easier like this, looking at you. You yourself, you admit that they are easy. Okay, but choosing the right answers is another thing. So that is it, okay. And please, let me also mention this as part of things that can help one sleep.
Reading.
Like it's reading part.
Yes, reading is part.
Reading is part. It's watching television part.
No.
So you see the trick. Watching television is not part. Reading is part. Okay. So take note of those things. You'll not meet it here one day. The next day you meet it somewhere in a different form. Let's look at this one. The next is conducting medication teaching with a client about close-up pain. This close-up pain today, they ask a lot. The next should include information about what weekly, at this one day, even if you close your eyes, you can answer. What is it? Who can tell the answer?
Close-up pain.
I think 2. Hematological Monitoring.
You think it's two, eh?
I think it's 3. Follow-up visit with a
It's
prescriber.
2.
So you've met this question on the English. What answer will you choose?
I'll go for 3.
I'll go for
Please,
2.
you can raise up your hand
2.
if you want to talk. Sherry, your hand is up. You can raise up your hand though, if you want to talk. Raise up your hand.
Okay, so I was thinking of 2 because clozapine, because of the zap over there, it zaps the white blood cells. So I was thinking that probably the white blood cell count
Sherry,
would be appropriate.
Sherry, and the zaps. Okay, that is fine. Ramatu, you want to say something, eh?
I was thinking it's
Okay, so anyone who thinks it's a different answer, the person can say it apart from 2. And let's see what you have to say.
I think it's 3.
So why 3? So that we don't.
No specific reason, but I know people on Desapane and Clozapane mostly go for follow-up visits with the prescriber. I think every month.
So one thing you should know about clozapine is that it depresses the bone marrow, something like that. Okay. So you're going to have issues with your blood cells, red blood cells, platelet, and white blood cells. But most of the time it's because of infection, white blood cells. Okay. So having this in mind, what do you think the answer should be? It's hematological monitoring. It's blood works, isn't it? When you pick someone's sample, for if someone, you see, it's weekly something that you have to do. When someone is on clozapine every week, you have to take samples for these things. Okay. Yes. So I've seen it. Let's pick something from the rationale. We are left with one last question, then we move on to mood stabilizers. So this one will be my final question here. Then move on to the next thing. A client is taking phenelzine. The visiting nurse is evaluating for client safety. What should the nurse include as priority teaching? What class of drug is phenelzine? Yes, anyone?
It's SSR.
Is MAOI.
It's monoamine oxidase inhibitors.
Yes.
Okay. All right. So what do you think the answer is?
4.
Was that difficult?
No.
Oh.
So you see,
But we
as soon
don't know
as
the name of the drug.
good, as soon as you recognize that phenelzine is what a monoamine oxidase inhibitor, you think about what? Tyramine. So over here, they could have said an option like restricting maybe aged cheese or something like that. They can give any food that contains tyramine, but over here they just consider to mention the tyramine itself. So always play smart, because even on the English, the wrong answers are also well calculated. The wrong answers, they know what sometimes students think about. Okay, so be very strategic in your test and open your eyes.
Oh, I called you. Oh, okay. That was earlier, but I'm okay now. I've actually joined the class.
The patients, we can hear you.
Yes, I'm in the class.
All right, let's look at mood stabilizers. Mood stabilizers. And when you hear of mood stabilizers, from here, the first thing that should come into your mind is what? What, especially for those of you who have kept longer, what mood stabilizer comes into your mind? Or when you have mood stabilizers, what drug comes into your mind?
Lithium.
Lithium. Lithium, simple. Please, if you are new with us, if you are new, don't worry. To get to a time, you are going to brainstorm and say lots of things, okay? So it's lithium. So let's talk about lithium. You know that the NCLEX also likes answering asking questions about lithium. So it is used to control manic episodes in bipolar disorder and for long-term prophylaxis against recurrent mania and depression. So we need to control mood, lithium. So precise dosing is based on what? The serum lithium levels. Mood stabilizing effects are usually seen in 5 to 7 days. So within 1 week for lithium, you should see what? The effects. Okay, after the initial dose has been given. But if you want to see its full effect, it's within 2 to 3 weeks. That's where you see the full effects of lithium. There's a contraindication. And when you are sensitive to the drug, that one is the number one contraindication. And you have to use cautiously in debilitated, dehydrated, or older clients. People who are severely ill, those who are dehydrated, those with cardiac issues, older adults, renal impairment, or thyroid disease, diabetes insipidus. So there's a connection to all of them. Take note of them. Okay. We are saying that please we'll talk about the fourth point here. We talk about it in detail. Okay. We will look at the normal value, what it does and some technicalities in it pertaining to the increase. We'll look at that very soon. We are saying adjunct therapy with a benzodiazepine can provide the sedation the client needs. So when you give lithium with any benzodiazepine, it is good. All right. So should be used only where therapy, including blood levels, may be monitored, okay, especially every 1 to 2 months, and as needed based on clients' or behaviors or what client is showing. Okay. So let's take note of this. We'll look at the technicalities in them very, very soon, so that when you see, I think in one of these days, I'll be posting questions on this lithium so that we can see. What is, I don't know whether we have it here. Okay, let us finish. I think it is here. So large changes in sodium intake may alter renal elimination of lithium. Increasing sodium intake will increase renal excretion. And that's a condition leading to loss of sodium, such as dehydration, sweating, and this may lead to toxicity. Look at this point. What does it tell you? Does it tell you that when someone is taking lithium, the person should rather increase or decrease sodium levels? What does it tell you?
to decrease sodium intake.
Are you sure?
No, they are to maintain their sodium
Yeah,
intake.
it's to maintain, not to increase or decrease.
So you see one trick there. Okay, so if you've been taking lithium, please, exactly as you've been taking your normal salt levels, continue like that. Don't increase it, don't decrease it. Any way you go, you can have issues with your lithium trough levels. Like let's say, yes, you can have issues with your lithium intake. You can easily get toxicity. All right. Then we are saying therapeutic level and the toxic levels are very close. Look at the therapeutic range. That is when someone is on the lithium. Between 0.8 to 1.4. I think some also say up to 1.2, isn't it? Hello? Or
Yes, yes.
I think some also give up to 1.2.
0.8 to 1.2.
But it's around, so the NCLEX say whenever they want you to suspect an abnormality, they will give you a wider range. Okay. Look at the WBC thing that we were talking about. We have some lab value which gives between 5,000 to 10,000. Others give from 4,000 to 11,000, of which all are correct. Okay. So let us take note of the therapeutic range and the toxic dose. Okay. And what lab value does it resemble? Look at it well. The value for lithium, what lab value does it resemble?
Creatinine.
Good. You fall down well. Good. So that is it. Okay. So if you know creatinine levels, lithium levels, some of them, you can just put them together. What about digoxin or digoxin?
0.5 to 2.
Normal levels.
Yes, for the digoxin.
You say 0.5 to what?
I said it's 0.5 to 2.0.
To 2.0.
Yes.
Okay. Okay. So that one is a bit different. So I think we can go with lithium, creatinine. There's one other thing that looks similar.
Is this urine specific gravity
Urine
1.10
specific gravity.
to
Good.
1.30, so it's looking within the same range.
Okay. Good. Good. All right. Thank you. So we can take note of that. All right. It is essential to monitor serum lithium levels frequently because of risk of what? Toxicity. So normally, the NCLEX will test you about the toxicity things and the rest. Let's look at the side effects and adverse effects. Okay. This one, so the NCLEX normally asks. So one, you know that lithium is a mood stabilizer. You know the normal therapeutic levels, right? You know that when you are dehydrated, please, when you hear of dehydration, it can come from anywhere. Whether you are running, you are vomiting, having the severe form of all of these things, you should know that all of these things can happen. Okay. So look at this one. Dehydration, excessive sweating, if you are taking diuretics. So all of these things can lead to what? Toxicity. So when they ask you any lithium question and they tell you the patient is dehydrated, the patient is sweating, the patient is taking diuretics, the patient is having diarrhea, suspects toxicity, which is likely to happen. All right. Side effects or adverse effects. The first one, we have fatigue, headache, lethargy. Then I narrate. Underrated, we have abdominal, like another one. We have abdominal pain, anorexia, but take notes that earlier signs. I think during my time I even had it. I remember clearly earlier signs of lithium toxicity. You have most of the GI symptoms, gastrointestinal symptoms. That is the nausea, vomiting. You see all of those GI symptoms. You normally have them, so take note of that very well. You can have polyuria. So you see metallic taste too. You can have metallic taste too in the mouth. So that one should also give you an idea that lithium toxicity is happening. Polyuria, glycosuria, nephrogenic diabetes insipidus, and then renal toxicity, and renal toxicity. So you can get all of these things as side effects. Polyuria, glycosuria, you pour out more urine containing glucose. Nephrogenic diabetes, diabetes insipidus. In diabetes insipidus, do you retain urine or you give out more urine?
You give out more urine.
Give out.
Give out more urine. Good. It's controlled by what?
ADH.
And ADH is produced from where? Or by which of them?
Posterior pituitary gland.
Good. So the posterior produces only two hormones.
Yes.
Then that one and which one?
Oxytocin.
Oxytocin.
Case died. Okay, let's continue. The next one we have what? We are saying reports signs. So you see signs that you have to report. So this one is adverse effects. Weight gain. When they tell you someone started, they had the question like someone started this thing. Someone started lithium and the person has gained, please, with the weight gain, when you gain a weight of, let's say, 2 pounds within a week, or 2.2 pounds within a week, it's a cause for concern. Okay, when you gain more than that within a week, it's a cause for concern. It means you are gradually storing weight, or you are gaining weight, something like that. You are gaining weight. That's the right term to use. So it's a cause for concern. Before your intake of lithium, you were not having muscle weakness, but now you have muscle weakness. It's one kind of adverse effect. Hyper irritability. These ones are just something that you can't keep your mouth shut on. Rigidity and tremors, they are all adverse effects. All right, so toxic effects are classified as what? Mild, moderate, or severe. So with the mild one, you have the value to be what? The highest value to be 1.5. And then that one can lead to mild CNS changes like lethargy, decreased concentration, slight muscle weakness, pulse, hand tremors, and mild ataxia. Okay. Let's look at the next point here. Moderate toxicity, to look at the value up to 2.5. That is starts from 1.5 to 2.5. And it leads to GI symptoms like what? Nausea, vomiting, severe diarrhea, blurred vision, tinnitus, muscle tremors or twitching, slurred speech, worsening. This one is more emergent, worsening ataxia and incoordination. Worsening, it means it is still, going down more. Okay. severe toxicity, which is above 2.5, it leads to nystagmus. You know that eye condition, nystagmus, hyperreflexia, impaired levels of consciousness, hallucinations, muscle twitching, fasciculations, seizures, or renal shutdown. Coma can even be part of it. Then, eventually, the person might die. Any question on this slide? Any addition? Okay, let's continue. Let's look at some nursing consideration. Okay, when taking lithium. The first one, assess mood, ideation, and behaviors frequently. Initiate suicide precautions if indicated. I think this one is self-explanatory, right? You assess for mood, it's like making assessments. And if there is any cause for what, suicide precautions, you have to, institute. Monitor intake and output ratios. Report signs of changes in totals. So let's say the patient has been gaining weight. It means the patient will have what? Less fluid intake. So more fluid intake and less fluid output, right? If let's say a person has this kind of the person has retention, that is more fluid intake and less fluid output, the person can gain weight, and this can lead to all that we are saying. You can get lithium toxicity, especially when you go through this kind of situation and you are still on lithium. The next one, unless contraindicated, provide fluid intake of at least 2,000 to 3,000 mL per day. Please take note of this one. It's the same as 2 liters to 3 liters per day. And that is actually within the normal maintenance dose for fluid resuscitation, right? The next one, monitor weight at least every 3 months. Monitor weight at least every 3 months. That's if only you want lithium. Monitor weight at least every 3 months. Assess patients for signs of lithium toxicity. So, which are the nausea, vomiting, slurred speech, decreased coordination, drowsiness, muscle weakness, or twitch in the upper part. So, if this occur, if all these things that you are monitoring for occurs, if all of these things occur, report before administration of the next dose. So let's say you are come to give, someone was already on lithium. It is time for you to give the next dose. As soon as you go to this patient, the patient tells you that he or she has been running. He or she has been running for, let's say, the past few hours. Please withhold the drug. Don't sell it. If the healthcare provider is there, try and communicate with him or her. All right. For safety. Any question? Okay, so what we looked at are nursing considerations. Let's just look at what to teach the client too, because it's like there are two things. The first one, take medication even if feeling well. Okay, so even if the client report that he thinks he's well, so he has stopped, don't do that. You encourage the nurse, no? So you encourage the sorry. So you make sure that the client takes the medication even if they are feeling well. You tell them that they are supposed to complete the full course and they are not supposed to stop until they are informed by their healthcare provider. And just in case a dose is missed, you take it as soon as possible. And on the necklace, look at this one. It says unless within 2 hours of next dose. So if it is within 2 hours of next dose, this one they can ask you a practical question on it. And this is from Pearson material. So let's say this is an example. Okay, so this is also another thing. So let's say we are taking a medication and it's let's say we're taking it 8 hours. You took the first one at 6. The next one you're supposed to take it at what 2 p.m. You took the first one at 6 a.m. You're supposed to take the next one at 2 p.m. If let's say somewhere around 10 p.m. sorry 10 a.m. you remembered you forgot to take your drug, you can take it and that is fine. Okay, but if let's say you just remembered around 12 p.m. you're not supposed to take it. You're not supposed to take it. That is what we are saying. So take a missed dose as soon as recommended, unless within 2 hours of next dose. So if it's let's say you remember it's around 12, then you have to wait and take the next one rather. But it should be 6 hours if it's extended release. Then the next one you're saying may cause dizziness or drowsiness. So because of these things that can come with the drug, kindly mute out. Because of these things that can come with the drug, you have to do what? You have to educate patients on what not driving or operating heavy machinery or doing any form of activity that requires full alertness. Okay, because it may lead to injury. All right. The next one. Low sodium levels may lead to what? Toxicity. Low sodium levels. So if you are having hyponatremia, if you are having hyponatremia, we can't give it to you because you will have toxicity unless we treat the hyponatremia first before we can start giving you this one. So take note. If you get questions around that, they are throwing all around. If you understand the concept, no one can trick you. And the water intake, we said it between 2 liters to 3 liters every day. Okay. And the diet with consistent and moderate sodium intake. So the sodium should be normal. Avoid excessive amounts of coffee, tea, and cola because of their diuretic effects. So you see, coffee has a diuretic effect. And this tea, Lipton, I mean, tea bags, they have high tendency to cause what? Diuresis a lot. For this one, I even have experience. Then cola too. So these drugs, they are like, oh, sorry, these things, they're like, they also irritate your bladder, urinary bladder. So if there's another question there, someone, I don't know whether someone who has been having urinary hesitancy, you don't have to give these things because they will irritate the urinary bladder for you to urinate a lot. So take note of them. Okay, so because they also have what diuretic effects, they can what they can cause toxicity. So we have to avoid. We have to teach patients to avoid excess amounts of this. Then the next one, avoid activities that cause excess sodium loss So notify prescriber if fever, vomiting, and diarrhea, which also cause sodium loss. Okay. So this one too, they can give you they'll not tell you that patient is losing sodium and sweat, but they can give you a scenario like maybe which of the following would we not recommend to a patient who is taking lithium? And the option would be like the correct option could be like teach patients or educate patients to have an indoor play other than an outdoor one. Okay, they can bring an outdoor one, or they can mention something like working in the sun or like doing something in the sun. And the trick over here is that when you are playing outside under the sun, you sweat a lot. Okay, so there's likely or there's the likelihood for sodium change to occur. All right, so that's one too. I mean, serum sodium levels, that's what I'm talking about. So that one too can lead to latent toxicity. So take note of that when they ask you questions like that. Please do you understand what I just said? Hello, are you
Yes.
here? Okay.
Yes, we understand.
All right.
And I don't understand.
Hey, and you've been quiet. So the thing is, you see, when you lose lots of fluid, when you are taking lithium, when you lose lots of fluid, when you are taking lithium, you have high tendency of getting lithium toxicity. So I said they can give you a question like, which of the following will you teach or will you recommend for patients? Okay. Like in that way. Or which of the following, yes. Let me put it in a simple way. Which of the following will you recommend for patients? An outdoor game or an indoor game? A patient who is taking lithium for this one. And I said in this case, an indoor game will be better. Why? Because it is assumed and it is well noted that, not just an assumption, it is noted that people sweat a lot when you are not the sun. And you can have sodium change, serum sodium changes when you are working on the sun through sweating and all of those things. You know that when you lose lots of sodium, you can get this toxicity. You can get lithium toxicity, right? When you lose lots of sodium, and when you don't get enough sodium too, you're going to get the toxicity of it. Okay, so when you work under the sun, you're likely to lose sodium and water, and that can lead to lithium toxicity rather. Did you understand?
Yes, please.
Hello. Okay. All right. So can we continue?
Yeah.
All right, so the next one, okay. Let's move
Yeah.
on.
Okay.
So weight gain may occur. So when weight gain occurs, follow principles of a low-calorie diet. Okay, you have to teach patients about this. But I've told you, when you say weight gain of more than 2 pounds per week, report to healthcare provider. Normally states 2.2, something like that. So it's like 1 kilogram per week, something like that. If you see something like that, it's not good. Consult with prescriber before taking any over-the-counter medications. Okay, before use of contraception or if pregnancy is suspected. So you have to also report to your healthcare provider when you're taking any of this because of drug-to-drug interaction. Okay. For these pregnancy things and the rest, when you are having thyroid issues, when it comes to thyroid, you don't stop it. Do you stop taking it when you are pregnant?
No.
Need it for continuous metabolism. Okay, something like that. But I think there might be changes in the dosage because metabolism normally increases when you're pregnant. So maybe your dosage might even increase. Okay, and so that is just a link. When you are pregnant, because there is a physiologic and metabolic change, massive one in your body, you have to tell your healthcare provider. And I think lithium too will have, especially with oral contraception, sorry, not oral. I think this one has to do with contraceptives itself. Okay, like if you are pregnant or you want to become pregnant, you have to decide with your healthcare provider before. And for clients with cardiovascular disease or over 40 years of age, you will need ECGs because of, it's placed with sodium. Lithium plays with sodium. Okay. Lithium has a charge of what? 1 plus, isn't it? Lithium, sodium and lithium, they all have charge of 1 plus. Like it's like what plus. Okay, so it's like they all have similar way of acting. That's why when you have one level down, you are likely to get the other one imbalance. Okay. So they all have to remain within the same level. So we have other mood stabilizers too. The main one that the NCLEX normally asks about is lithium, but we have some other ones. So carbamazepine and sodium valproate have acute anti-manic and long-term mood stabilizing effect in bipolar disorder and are better than lithium in treating mixed or diphoric dipolar states. You have this drug too here. It's also used for long-term lamotrigine. It's used for long-term maintenance therapy to prevent delay or relapses. Atypical antipsychotics too will help control symptoms of mania and may be used in combination with lithium to stabilize mood. So sometimes they're even used in conjunction with lithium to stabilize mood. Although olanzapine may be used for long-term maintenance therapy. So these are some other ones, but the main one is the lithium. Okay, so this one was just brought in here just for you to know that they can be used to also manage, depending on what is happening. But actually, sodium valproate is under what class?
Mood
Cheryl,
stabilizers.
are you sure?
It's an
Sodium
kind of
valproate.
anti-seizure.
Nah, it's for bipolar.
Bipolar.
Sodium valproate.
Oh, anti-seizure.
Anti-seizure, like
Anti-seizure.
epilepsy and all that.
Anti-epileptic, right?
Yeah.
Anti-epileptic or anti-seizure. So do we use to abort acute episodes of seizures?
No, long term.
No.
So it is used like as a preventive measure, okay, to prevent seizure from happening. Who can give me other anti-seizure medications like that, like antiepileptic?
Phenytoin.
Phenytoin. Another one.
Phenobarbital.
Phenobarb is under it's an
Benzo.
yes, barbiturate. It's an barbiturate.
Yeah.
So not that one. You've mentioned sodium valproate. You've mentioned phenytoin. There's one common one that the English also has.
Diazepam?
No, not that. Diazepam is benzodiazepine.
Yeah.
Painting.
Do you remember Keppra? Keppre, Keppra.
Yes.
Another name for Keppra is what?
Oh,
Levetiracetam.
That's where,
Levetiracetam.
yes, levetiracetam. Yeah. Okay, so that is also just by the way. All right. So let's look at some contraindications. Contraindications when you are taking some of these drugs. So with the first one, carbamazepine, you are saying hypersensitivity or bone marrow depression. When you have bone marrow depression, please, for any kind of treatment that you are undergoing with carbamazepine, if you are hypersensitive, sorry, if you are hypersensitive, we can't give you. We can't give you. If you have bone marrow suppression or depression, we can't give you because this one will further cause bone marrow depression. Then pregnancy to unless potential benefit outweighs fetal risk. Okay. So that is the exemption for pregnancy. And use cautiously in clients with cardiac or hepatic disease, prostatic hyperplasia, or increased intraocular pressure. Then with valproate, when you are hypersensitive to it, no. Hepatic impairment, no. Then avoid use with products containing tartrazine. Use cautiously with bleeding disorders like liver disease, organic brain disease, bone marrow depression, renal impairment. So it's like all of them, they have common things like hypersensitivity, bone marrow suppression, liver issue. So I said liver issue. Renal issues rather. I think even yes, liver issues are also even part. So they look similar. Okay. They look similar. And safe use in pregnancy is also not established. So this one too will also depend on less the benefit outweighs the risk. Okay. So these are some of their side effects. Of course, carbamazepine will cause all of these things, right? Dizziness, ataxia, sedation, headache, all of these things here. And adverse effects tends to include heart block, bone marrow depression, respiratory depression, exfoliative dermatitis, Stevens-Johnson syndrome. That's a rare case. Then liver failure, pancreatitis. These are some of the adverse effects and the side effects. They are very similar. Okay. When it comes to the adverse effects, with the sodium valproate and the carbamazepine, they are very similar. Nursing considerations. Assess frequently for seizures. Don't worry, we'll close right now, okay? Those of us who want to close early. Assess frequently for seizures, seizure activity when taking carbamazepine, and assess for facial pain because of possible please write it somewhere. Trigeminal neuralgia. I found this question somewhere related to carbamazepine. Trigeminal neuralgia. You know the trigeminal nerve, right? It's part of the cranial nerves, isn't it?
Yes, nerve 5.
Good. So it innervates the face. There are three faces in there. When you read about it, you see. That's why it's called a trigeminal nerve.
So it's three.
Measure. Come again.
The trigeminal nerve, we have the ophthalmic nerve, the maxilla, and the mandibular.
Good. So those three faces of the face, that is it. Please let us revise our cranial nerves. It's very important. Sometimes the English ask questions on it, and let us also know whether they are both sensory or they have both actions. Okay, motor sensory. Sometimes they will ask you a question. Patients, like which of the cranial nerves is likely at fault, or is likely let me say that it's likely at fault. when patient has difficulty breathing or something like that. Then you start thinking of the vagus nerve, and some know where it innervates, right? Around the chest, and then climbing up. Let us read about them. Okay. Measure white blood cell counts weekly and provide weekly medication. We've talked about this, carbamazepine, because of their tendency to suppress or to depress the bone marrow. Check routine CBC, that's complete blood count and serum iron weekly during 2 months and yearly thereafter to monitor for anemia caused by bone marrow depression. So please, when you hear of bone marrow depression, think about all the 3 types of cells. Platelets, white blood cells, and red blood cells. Perform liver function tests, urinalysis, and BUN routinely. Measure serum ionized calcium levels at least every 6 months. What are the normal BUN levels?
7 to 22.
Okay, 7 to 22. Some also say, I think 10 to 20 is also popular, right? 10 to 20, and it's easier to capture. Okay, so that is it. Then, what are the normal calcium levels? Please, all this
8.5 to 10.5.
8.6 to 10 points. Some say 9 to 10.2.
Come again. 8 point what?
8.5 to
8.6 to
10.2.
0.2, yeah.
Okay.
8.5 to 10.5. Some
So
says
sounds
8.5 to
good.
10.5.
Good. So you see, they are around the same value. Okay. If they want you to suspect, I've seen hypercalcemia question, and the calcium levels mentioned was 10 points. Is it 10.8 or so? Okay. So you should know that 10.8 is far away from the normal. I mean the highest point. Okay. All right. So that is also for this one. I think we should leave the rest for, yes, we should leave the rest for another day because of our time. It's almost 5 minutes past time. If you have any question, you can ask. If no question, then I think you are fine. Someone is calling Rose. If there's no question, then I think that is fine. Thank you.